give me the intro to Dr. Huda.
Okay, so I'm Dr. Huda. My first name is Huda Aman is my last name, and I'm a dermatologist here in Ethiopia. I'm based in Ethiopia. I did my undergrad and postgrad studies both here in Ethiopia, and work full-time almost. I work two jobs actually. I
Oh,
work
really?
at a general hospital every morning, and I also work at a hair transplant center in the
Wow.
afternoon. We do also dermatology consultations at the same place. So I usually do the dermatology consultations, and I guess that's it. Well, dermatologists in Ethiopia are very few, by the way. For almost 100 million population, we have maybe 200 dermatologists. Can you believe that?
Really? Wow.
So
But 100
yeah, very
million,
few.
you've got 200 dermatologists. That's crazy.
We're just 200. I know.
Why so low?
Yeah, so very.
That's
Well, the
interesting.
training started. The training did not stay long, honestly, and
Hmm.
well, healthcare is still at its infancy here. That's why I guess,
Okay, fine.
and
So do you think it's the
that's what
need
keeps the
for
work pace.
I suppose it's more focused on the more acute specialties like emergency medicine and, respiratory, gastroenterology. I think those
Exactly,
ones are still,
exactly.
especially in, the developing countries and things like that. Those specialties will be more of a,
Gynecology,
yeah,
surgeons, yeah,
the
these
surgeons,
specialties are
yeah,
more.
yeah, are very important.
Dermatology is kind of more of a luxury here now.
So your two jobs, your first job, you're working in the hospital. Are you just doing general dermatology clinics, or is it focused in a subspecialty?
No, general dermatology clinic. I'm
Okay.
still
And
just a general dermatologist.
right.
So I do clinic, maybe inpatient consultations, and so on.
And what do you tend to see? What's the distribution of your skin disease over in Ethiopia? What conditions are you seeing day to day?
Now that I'm working, even the hospital is a private hospital, so now that I'm working in private setting, I see the common things: acne, melasma, rosacea, and so on. But during our training and at the government setting, we have more of infectious conditions like leprosy, leishmaniasis. We see that a lot.
Okay. And is your time split?
Psoriasis.
Yeah. And is your time split kind of more in the private sphere or a more kind of government based healthcare system? What is your split of
Like
time?
me, more of the private. Currently, I'm just working in the private. I
Okay.
had this exposure to the government while I was a resident, actually.
Yeah.
But
Yeah.
majority of the 200 dermatologists I mentioned are government based, and they work in private just as part time.
Okay.
We
Fine.
have this. We take most of our training at the biggest dermatology, I can say, hospital or center in Ethiopia is
Mhm.
based at the Leprosy Research Center, the All African Leprosy
Mhm.
Research Center.
Mhm.
So
Hi, Dr.
we do
Sarah.
dermatology and leprology together.
I can see Sarah joined the chat as well.
Yeah,
um,
yeah. First time I saw you was with the Dr. Sarah.
yeah, yeah. No, we've done a couple together actually. But just back on that, so leprosy, there's a lot of, I suppose, resource dedicated to leprosy in Ethiopia, I guess, as well. It's something we don't really have in the UK, which is interesting.
Yeah, I bet. I can imagine. Yeah, we have all infectious disorders. That you can see a lot
Yeah.
of infectious dermatology here. You can see a lot of mycetomas, lymphedemas, elephantiasis, and so on, even on the streets. It's
Really? Wow.
yeah, it's quite interesting.
Yes, that's just stuff that we don't see that often over in the UK. Elephantiasis, definitely. I mean, you know,
Yeah,
it's
I can
very, very
imagine.
little.
Yeah.
And leprosy as well. I've hardly ever seen it in clinical practice. I mean, I've seen it for
I can
exams, and we have to know
imagine.
about it for the exams. But yeah, in actual practice, I'm not treating that on a day-to-day basis. So
Honestly, I don't also treat that now. For now, I just see, as I said, the common conditions.
yeah,
Acne is very, very common, and melasma in our skin of color, again, is
yeah,
very common and very challenging.
yeah, yeah. So, I mean, I actually was really interested in asking you what the healthcare system was like in Ethiopia. And I suppose you've already said it kind of a little bit. I suppose there's the private world there, and then there's the government funded, like the equivalent of our NHS. Is that what you're saying? So,
Yes.
is it mostly government funded for most people in Ethiopia?
I can say that, yeah, for most people. It's
Yeah.
more, no, the healthcare is kind of poor, honestly.
Mm.
You there's people struggle a lot to go to these government places because it's, again, the hospital setups, the facilities, and the number of people is not balanced.
Yeah.
So there is a struggle there. People with, if you can afford, most people would prefer to go to private settings for the ease and for the ease of getting access to the dermatologist. Especially those at rural areas, it's again more challenging,
Yeah.
and they
Yeah.
come usually at very very late stages.
Okay.
The thing here is, other people also treat dermatology conditions at low level clinics, health centers, and so on. So
So
sometimes you
more.
just see more of challenging cases,
Yeah.
referrals, more or less.
So your general practitioners over there are treating dermatology as well, like they do here in the UK.
They do, yeah,
Yeah.
they do. Some of the cases they do.
And what percentage of your total doctors do the general practitioners make up? So in the UK, we're kind of like, I don't know, 45 to 50% of us are general practitioners. Is that true, Sarah, if you're still watching? I think it is 45 to 50%. But if you tell me in Ethiopia, what percentage
I
are
don't
kind
know
of
the figures
generalists?
exactly, but much more general practitioners
Much
because
more.
specialty trainings were few. Recently, we're getting
Mm.
more specialty training. So specialty trainings are few. And by the way, we call general practitioners those that just graduated from med school.
Really?
Med school,
Wow.
yeah, after
Okay.
med school, we just do about a year of internship, and then you're a GP.
Okay. And then
There
you
is
also,
no postgraduate for a GP.
so does everyone start out as a GP after med school?
Exactly.
Okay.
Yes, I worked as a GP for like six
Right.
years.
And how long do they typically work as a GP before specializing?
Minimum 2 years.
Hmm.
Depends on you getting a training, the chance of a training at
Right.
any facility for the residency. So sometimes people might not make it to residency.
Yes. Yes. And what's the competition ratio for like dermatology in Ethiopia? Because here in the UK, our residency competition is getting harder and harder every year. So at the moment, it's something like 6 to 7 to 1 applicants to places for dermatology specialist training. I'm guessing it's probably similarly high in Ethiopia. There's like a big bottleneck.
Much higher. For
Much
dermatology, much
higher.
higher.
Really? How much
Yes,
do you
yes,
think?
very much higher. But maybe 1 in 10 chance of getting into a
Wow.
dermatologist program.
Okay. And is it quite a popular field in Ethiopia, or is it becoming more popular
Recently, just recently.
just recently?
Very recent. Yeah, people did not have the awareness of dermatology. I guess sometimes people saying, "Is there a skin specialty?" I never heard of that.
Really? That's so interesting because here we take it for granted. We're just, in the UK, and, everyone knows about the
Yeah,
dermatologist and sometimes they go to their GPs and they're saying like, when are you going to refer me to the dermatologist? I want to see the dermatologist now. So it's really interesting that you're kind of in your area of the world, dermatology is still quite a new thing. And it's been around for a bit of a less time than it kind of has over here. And maybe, it's interesting. I think at the beginning of these phases, you've probably got, since you're a specialist in dermatology over there, you've probably got a lot of power to change things if you want, and like set up how the
exactly.
infrastructure works for treating people with skin conditions. So it must be quite exciting,
Exactly.
I think.
It is. I'm also a board member of the Ethiopian Dermatology and Venereology Society. I am the public relations officer, so we do a lot of work. Yeah, it is a lot of work.
That's good. And do you have, I suppose, in that kind of board membership position, do you link in with other countries or, associations of dermatology in other countries? Is there much networking going on at the moment?
Yes, mostly.
Yeah. Which other
Yes,
places?
recently, yeah. I just joined this year African
Mm.
Society of Dermatology.
Yeah.
Yesterday I had a webinar. I presented a case to the African Society of Dermatology, right this time, yeah, just yesterday, 6 p.m.
Okay,
So yeah, we do that. We're
that's
trying to
good.
join to the International League of Dermatology as a
Yeah,
society, but
I
we're
always
growing, I can say that.
Yeah, no, one thing is I've always been invited to be like a speaker at, this and that conference in a different part of the world. Not always dermatology. It's actually sometimes different specialties. But you're probably getting similar invitations, and sometimes you have to actually evaluate, is this a real conference that I'm getting invited to? Or is it something like, which is like brand new and not really been verified that much? I mean, probably Sarah gets these emails as well, all the time. But I don't. Do you get approached by different people in different parts of the world saying, "Can you speak? Can you present your findings on this subject within dermatology to us?" You must do.
We do. Certain dermatologists, especially those working at the rural areas, they have
Yeah.
certain interesting cases, and they do. Common cases, we have a doctor called Dr. Wendemagin. He always presents cases on scabies. He's done a lot of research on scabies,
Yeah.
and he goes to a lot of conferences presenting those cases. As I said, we have a lot of interesting, very interesting cases, and the thing is, the patients come at a very late stage, so you get to see the lesions at a very, very late stage. So
Okay.
sometimes you get very interesting pictures, interesting case reports, and so on. And yeah, sometimes they do get invited to
And
international
do
conferences
you
and present those
get,
kind of
because
cases.
some of us actually, I know some dermatologists who go abroad to African countries from the UK, and they work for a few weeks in a dermatology clinic in Africa, and then come back, and just more to, because they see a different kind of dermatology out there. I suppose in Ethiopia, do you get some of us dermatologists from either the US or
Yeah,
UK
yes.
or Western Europe coming?
Yeah, I've met a lot, especially while I was in my residency. Yes, we do have. We had, forgot his last name, Dr. Richard. He comes from England.
Oh,
Yeah.
really? Okay.
And we also had another dermatologist from Canada. We get those sometimes. As I said,
Yeah.
it's since it's a leprosy research center, a lot of people come there, and if they spend probably 3 or 4 weeks, we arrange and they give lectures to our residents and so on. So we do get
Yeah.
that a lot. Yeah,
Yeah, we get bursaries to
we need to invite
travel.
you someday.
Definitely, yeah, I'd love to come. We do actually get bursaries from our Association of Dermatologists here to travel, so a certain amount of money to go abroad. I think it's certain countries that they fund, or I think it's sometimes it's like general travel to a different dermatology in a different part of the world, and I'd love to do that. It's something like, because I'm still in the training pathway in the UK. I'm near the end now anyway. I've passed my board exams. But still, like,
Okay.
while we're in this phase of training, we still, our time is very much just really focused on learning, being in clinics every single day, seeing a lot of emergency dermatology. So it's quite hectic and busy. But once I finish that period, I'd love to go abroad, and head to places like Ethiopia and just see how it's done over there. And it's something I've not done enough. I mean, I've been to Japan and I've seen dermatology in Japan, and they've got a lot of blistering skin disease over in Japan, autoimmune skin conditions, which is fascinating. And I did that for about a period of 6 weeks on my elective when I was a medical
Okay.
student. But that's been the limit of it so far. And apart from that, it's just, plain old UK dermatology here. So yeah, no, it's fascinating, how dermatology is practiced in different countries. Cool. So I suppose the other question I had in my mind was how your TikTok journey, and how you found the platform, how you found growing on the platform, some of the things that you found difficult, or some of the more enjoyable factors. If you could go through a few of those, I'd love to kind of pick your brains about that.
Yeah, my TikTok journey, kind of interesting how I started it. Here skincare is, just like the rest of the world, how it is with skincare now. So a lot of people come on TikTok, talk about skincare, mislead people with
Yeah,
skincare,
yeah, I know.
and even a lot of GPs, by the way, not just
You're
other
not just,
people, even
yeah,
GPs.
yeah,
And
yeah,
seeing that, I kind of felt like, it's time for a dermatologist to join this and, people should know the actual difference. And first time when I joined, I got people asking me, they thought I was just like an esthetician or something. Even
Yeah.
it's kind of quite interesting that people do not even know the difference between a dermatologist and an esthetician. So they would go like, "How did you get your
Frustrating.
certificate? I want to get those training and so on." And you have to tell them you have to go to med school first. And people go like, "Are you actually a doctor?" I even get patients who come complaining of acne, and they go like, "Do you also check the hair or the foot? I have a lesion. Is that your
Yeah.
specialty too?"
We get that all the time. Yeah.
So mainly TikTok was educating people and trying to give them, the right information, because skincare products here are not so cheap, and
Right.
you could get someone coming on TikTok and telling them a simple CeraVe face wash is going to get rid of their melasma.
Mm.
And people have to pay a lot to get those kind of products. And so putting those on the right, that was my intention when I started TikTok.
Yeah.
And it actually grew so fast, especially
Yeah.
I got 20,000 followers in 24 hours. I remember the
Yeah.
first time I started TikTok.
I was going to say, I've just noticed that you've recently hit the 100K mark. So that's, it's a big milestone, and congrats. And,
Thank you.
I thought that, there must have been the journey to get there. There's always like difficult periods and periods where it comes really easily. And then you think like, how did I get so many followers so quickly? And then, then it goes down and you're just like, what am I doing? What do I need to do differently here? So that's really interesting that you had such an amount within 24 hours. And then how has it been the rest of the time? Has it then generally been quite
The
slow or
rest of the
quite?
time is almost a year. Then it kind of got slow, honestly. Maybe I started getting boring because I kind of post not so often, maybe once
Yeah,
a week and so on. As I said, work is busy. And
yeah, yeah.
well, but it is growing. It is growing. I
Yeah,
think
I mean,
100K is not.
that's the thing, isn't it? It's
It's almost.
persistent.
It's a year now.
Yeah, yeah. So you've just been on TikTok for over a year?
Over a year, yeah, a year and a few
Yeah,
months.
over a year. Yeah, about the same for me. I think probably a year and a half, almost 2 years now. And for me, it's just been like a gradual increase. I've never seen like such a spike, a volatility spike, to kind of make me question like what happened there. Why did that suddenly do that? Did that happen for you? Did you have like a certain video where you thought, how did that get me 20,000 followers? Like, and did something kind of unlock in your brain
It
thinking,
is. It is.
that's how I
Yeah,
did it?
it is. My first video was just an introduction. I came
Yeah.
out, mentioned my name. I said I was a dermatologist, and if anyone was interested in skincare, to join me. That was my first video. That's
Yeah.
the one that hit the most, honestly,
Wow.
just the introduction video.
It's fascinating, isn't it? How these
But the
algorithms work.
TikTok algorithm is kind of weird, right? Like you never know which one is going to,
Yeah, it's
you know,
evolving, it's
get a lot
changing.
of these.
I don't know if how much it's applicable to our audience, but I found like views are getting a lot less over the past like 3 months, or 3 or 4 months. That I found that there have been fewer views for content. You need more, I don't know, certain kind of eye-catching content to really get people watching your videos or to hook them more. And interestingly about the TikTok thing, in that in the last few days, I found that TikTok is really promoting longer videos. So they are kind of incentivizing going 1 minute plus, which I don't really do.
Okay.
And I'm just like, but then I
You
did do
mostly
it.
do duets, right?
I don't really do duets, actually. I don't do lives. So
Reactions?
this is
No,
quite
you do.
special for
No, I
me.
mean you do reaction videos to
I do a lot of
pimples.
reaction video. Yeah, the pimple popping is the bread and butter for me. And because people just love it.
Yes.
Like,
Wow.
people,
I love it too, honestly. That's what I watch on TikTok.
yeah. So I mean, that's naturally what's worked for me. For other people, different things. I think, there's some dermatologists who are very successful just talking about, skincare routines and the way to do things and how they order their skin
Yeah,
and
yeah,
what
right.
skincare routine and what products they use. But I never found for me those videos really interested my audience. And I think, a lot of my audience just, mention my personality or something. It has to do with personality as well. And I think
Of
that's
course. Yeah.
because what I found with TikTok is that it's the number one platform where entertainment is important. You have to entertain on this platform as compared to YouTube or Instagram. And if you don't do
Exactly.
that, you're not going to get the engagement, which is, which as a doctor is quite difficult, because we're not always positioned to entertain. Like our day job, I'm not there going to entertain patients. That's not what. that's not my
It is true,
primary end
right?
objective. But yeah, but here on TikTok, it's a different world. It's crazy. It is crazy. But you know, it gives opportunities like this to, you know, link with dermatologists from other parts of the world, which I wouldn't have kind of done otherwise. But yeah, hopefully that's brought a flavor to our audiences of like our journeys on TikTok. Like for me, I started and my videos were getting maybe like hundreds of views. And from 0 to 10,000 followers took me maybe about a year.
Yeah.
So it's, you know, it has been a bit of a slog. But that's just the platform for you, I guess. I was going to
But
say
it's
how many.
kind of fun, right?
Yeah, of course it.
Short
You know,
videos.
that's why we
Very fun.
continue. That we continue because it is, you know, I suppose one of the reasons why I continue posting on TikTok and things is that, you know, I view it as it's part of my life in terms of like, I'm doing dermatology day to day, right? But I'm also doing it on here.
Yeah.
Technically, I've still got part of my dermatology hat on, and, you know, I can take my professional brain and use it to, so for example, the reaction videos, I'm reacting to things which I perceive are done well or not so well. And then I can use all the
Exactly.
knowledge of the dermatology that I know to kind of give my audience more of an insight, which is
Are you
interesting to
getting
me. That's
questions
why.
from your audience? You're
Yeah,
getting
so
questions.
we've got 468 likes, which is pretty impressive, actually. But I don't know. Yeah, if any audience members here have questions on any
I've got
parts of,
4.2K likes here.
have you? Oh, 10 times more than me.
Yeah.
Oh my God. Well, I mean, hopefully
Yeah, a lot of questions.
some of my followers can see your audience, and
Yes.
likewise your
Yeah, you
followers
need
can
to.
see mine.
Okay. Yes. Remember to follow Dr. Sina, everyone.
Cheers. Thanks. Similar for Dr.
A
Huda.
lot of
Go and give her a
people.
follow.
Thank you, Anwar. Thank you, Anwar Saeed. Thank you.
Does anyone have any skincare questions? It'd be a bit bad if no one gives a. Sarah's asked
Yes.
a
Go
question.
ahead and ask your questions.
I think we've got one from Sarah saying, Huda, what made you want to do derm?
Um, Skin is fascinating, honestly, really. Well, I have a little confession. I wanted to be a gynecologist at the beginning while I was working as a GP. I practiced a lot in gynecology, and that was my plan for residency. But if it wasn't the gynecology, then it was dermatology, definitely. Because I find skin very, very interesting. And the other thing is, I found it that it's still growing in Ethiopia, and I felt like I could do much more with this. You know, the like the field is very, very open to do many, many things with dermatology here.
Yeah, I'm jealous. I wish it
Honestly,
was in that phase over here, but right now it's, you know, it's been out around for years there, and I feel like the ability to
no, but
change.
still, even in your setup, like it's still something growing. Yeah, you get a lot of new, especially the cosmetology part.
Yeah, I mean,
Honestly,
cosmetics is
cosmetics
always
exactly.
is always growing in everywhere in the world. I mean, especially in the US.
It is.
The thing, how it works in the UK is that we, as dermatologists, we are mostly working within our national healthcare system. So we don't really do any cosmetics work until we become consultant dermatologists. And that's basically like around 15 years out of med school. Or is that right? No,
Okay.
about 15 years total from the start of med school to the finish, actually. So, you know, you're talking quite a long time until we actually start doing the bread and butter kind of cosmetic kind of stuff if we want to do it. And some dermatologists don't even go that way. They just, you know, stick with seeing, you know, severe psoriasis, eczema, you know, skin
Exactly.
lymphomas, and never want to do cosmetics, which is equally fine. So yeah, unlike
But
the US.
still, with even with medical dermatology, with still growing now, coming to psoriasis. Every time we hear new treatments with the biologics, things are changing really fast. I think
Yeah. Are they available in,
dermatology is something.
are the biologics
No,
available in Ethiopia? Not yet.
no, we
Yeah.
have difficulty. Yeah, not yet.
And I can only imagine that the cost when it does come over there, it'll be tremendously high,
That
probably.
is the problem. It's kind of frustrating treating psoriasis now, knowing that the
Yeah,
biologics exist and we don't have it
yeah.
here. So we treat psoriasis with methotrexate mostly.
Mhm.
That's it.
And
That's
then
the
yeah.
option we have.
And so what afterwards? What do you tell the patient if methotrexate doesn't work? What you go on cyclosporin maybe, and then
If available. Cyclosporin, if available.
if available, yeah,
If they can
that's
pay for it.
crazy.
Yeah,
Yeah.
even that, if available.
Because right now, so in the UK, of course, we've got, we try methotrexate, cyclosporin, we can try these systemics, and then you've got the biologics, and you've got all of these different biologics available, and you can then tailor them to your patient and see, what is most suitable to the patient. So, for example, if they've got severe heart failure or history of multiple sclerosis, like you wouldn't go with the anti-TNFs, you'll try a different class. So, it's getting so individualized over here, the medicine, that it's a good thing
Yeah.
for the patient, but it's interesting to hear how, like in Ethiopia, certain classes of medication you just don't have access to, which is, shocking, I suppose, in some instances, really thinking about it.
Exactly. So with psoriasis, it's just methotrexate. With atopic dermatitis, we just have prednisolone. Honestly,
Yeah,
that's it.
yeah,
If we go to systemic,
yeah.
these are our only few options. So kind of challenging. Even
Sarah's on.
topicals, we don't have much. We
Yeah,
don't have much options even for the topicals. We kind of use a lot of compounding treatments. We get the
yep.
pharmacies prepare it. Yeah, we order compounding treatments. Do you use that a lot now?
I mean, for psoriasis, we use Dovabet, so calcipotriol and betamethasone. I'm assuming
Yeah.
that's what you mean by the
So you have it
compounded.
just ready made.
We've got it
So
ready made in a
like we go
formulation.
prescribing how much percentage of salicylic acid and urea to add into a steroid. We prescribe it like that and they just mix it up at the pharmacy and give them.
So you can customize quite a bit. So you customize a little bit. You say like, I want,
Yes,
32% salicylic acid with white soft paraffin.
we can
Um,
do that. We can do that. By the way, I love that. I love that. Sometimes it's much more effective when we customize it on our own, you know?
that's
So I
interesting.
could, yeah, depending on the lesion, when you look at the lesion, if you feel the scale is like a little thick, you could go like into 5 or 6% salicylic acid
Yeah,
with a
we
dermovate.
we can't customize like that actually. Oh, I think you paused. Hopefully, there's not internet issues, but it sounds like there is. So you just cut out there for a second. Oh, I hope we can get to that.
I got it.
You're back
Internet.
now.
I'm
Yeah, that's
back. I'm
interesting
back.
because we can't customize to that extent
Yeah.
with, I mean, sometimes, like rarely we ask pharmacy, we say,
Let
can
me
you
tell you
put,
something interesting.
yeah,
Acne, mild acne, like those with more of predominant comedones, we give a combination of 3% salicylic acid with 2% sulfur, and we just combine that with a Nivea cream, and we get very, very good results. Very
okay, that's
good.
interesting. So you're not using topical
Better
retinoid?
than a 2% salicylic.
Are you using any
We do
topical
use topical
retinoids?
retinoids. We have, yes, we do. We have tretinoin and adapalene. We use that too,
Is it okay?
but we also use the salicylic acid. And
Do you use
our
them in
patients here are not
combination?
very compliant, by the way.
Do you use like in combination on the same day or like different days of the week?
What and what?
Sorry, the salicylic acid and sulfur. Say if you're using comboing that with adapalene, would you say to a patient, well, use adapalene certain days of the week and then use the
Exactly,
salicylic
exactly.
acid, sulfur
Since it
another?
takes
Yeah.
some time, since it takes some time for the skin to to adapt to the retinoids, I could start them with twice a week of a retinoid and maybe twice a week of the salicylic
Yeah.
acid based compounding treatment. And then eventually I could stop the salicylic acid and then keep them on adapalene for maintenance.
Okay. Fine. And do you get to follow up your patients? Because when I see my patients here in our health service, it can be months before I see them again. I don't know. Do you see them
You have to
sooner than
get to
that?
follow them up.
Sorry?
Yeah, yeah. Anytime I appoint them, they just come. I could appoint them every month, every two
Yeah.
months.
As in
They
sometimes
come.
like
Access is not. It's
it's not
at
the
the
issue.
private setting. Access is not that much difficult. They just come to the hospital,
Yeah.
pay for the consultation, and just go directly to the dermatologist because it's a private setting. So they could come anytime you appoint them. They just come.
Yeah, that's the thing. In
You'll
public
get your
setting,
follow-up.
for us, access is a real issue. Sometimes I want to
Exactly.
follow up someone, but I can't. I don't see them again for another 5 months, unless
I
they are
have like
completely
patients
flaring.
who are on tretinoin, and when they have to travel abroad, some people just move to Europe or America, and when they have to travel, I have to ship them back to adapalene because that's what they're going to get over the counter there.
Yeah, yeah, that makes sense. We've got a
Because
question
I
from
know that they will not get the access for the
yeah.
prescription. I know how difficult it's going to be there. Yeah.
Sarah's asked another question about what are the skin cancer rates like in Ethiopia?
Skin cancer.
Skin cancer rates in Ethiopia.
Definitely not as common as in white skin.
What's your
Definitely,
most
I can
common
say
skin
that.
cancer? Because over here in the UK, we see most
SCC.
commonly, we see BCCs more commonly.
Here, more common is SCC.
SCCs, that's interesting. And for those who
Yes.
don't know, actually, probably for the chat, because people are thinking, what are all these acronyms people are using? So basal cell carcinoma, a certain type of skin cancer, and Dr. Huda's what is squamous cell carcinoma. So a different type of skin cancer, but they're both skin cancers.
I
Okay.
my actual my qualification exam, my research was on. I did a research on the biopsied skin conditions, and skin cancer was rated around the sixth or seventh, and from that, SCC was much more common. Almost two-thirds of conditions were SCCs than
Wait, so,
BCCs,
so skin
and we
cancer
get
was,
even melanomas.
yeah.
Not so, yeah, it's probably sixth or seventh on the list. I
Oh,
kind of
really?
forgot, it was
In your
4 years
exam, it
ago.
was sixth or seventh on the list of
No, no,
commonly
not in
run.
my exam. I'm saying I did a research on my topic was on clinical histopathology correlation of skin diseases,
Okay, fine.
and I saw the number of biopsied skin conditions,
Mm.
and skin cancer was not so much common. It's not common in black skin, honestly. And from that, SCC is the most common one. And SCCs, again, more common on the limbs, coming after chronic wounds, are more common than on sun-exposed areas. We don't get much
Mm.
cancers on sun-exposed areas.
We've got another question.
The actual melanoma is common here.
Acral melanomas. Okay, that's interesting. Yeah. So not typically on the sites not on the sun exposed areas, so more on the hands and feet.
Not so much, yeah.
Yeah.
It's dark skin mostly here, so
We've got
not so
we've got a
much.
question. We've got a question from F Xavier. Ask her about cooler. What is cooler? I don't know what cooler is, so don't ask me.
I don't know. What
he
is
says
cool?
he says you only find it in Ethiopia. Um, I'll have
I
to
don't
look that up.
understand.
I don't know that about that one. It's probably some condition, or maybe an alternative name for a condition. But yeah, we'll have to look at that one. Good. I don't know how long we've been going for now. Does it
How
say
long
it?
has it been? Over half an hour, yeah.
Is it over half an hour? Shall we slowly start maybe wrapping up?
Okay, oh yeah, we should.
But yeah, it's been really good kind of doing this kind of duet. And definitely I want to do more of this type of thing with different dermatologists, and definitely Dr. Huda, we can go again, maybe like on a specific topic another time. But this was more like a general get to know each other chat, which is fine as well.
Yeah.
And I've really enjoyed it. And yeah, we've not had
Thank you
as
very
many
much, Dr.
questions.
Sina.
We haven't had as many questions as we'd like, but hopefully in the future, we can
I
get
had a
more.
lot of questions, but they were the normal questions I get when I go on live because I don't go on live very much
Oh, really?
often.
What questions
So
do you
I
get?
just like, what do I do for my melasma? I came to the OPD and I didn't find you, and
Oh,
so on.
okay,
Somebody
fine.
asked if you were married,
Oh, yeah, I know. It's crazy, isn't it? Okay, fine.
and
Yeah,
pretty much those, yeah, the routine skin questions.
the routine stuff. Yeah, absolutely.
So
Good.
maybe I'll just stay back here and answer those questions. Was very nice having you, Dr. Sina. Was kind
Absolutely.
of interesting.
Absolutely. I hope it doesn't. So if I quit now, would it just, hopefully it doesn't quit both of us, or maybe it will. So
I don't
you
know.
may have to go and open up a separate host, but I'll try to leave just myself. And so if anyone else wants to ask
Yeah.
Dr. Huda some questions, you feel free. Let me try and do that. Okay. Yep. So I'm
All
disconnecting
right.
from
Bye
you,
bye.
but it's lovely, Dr. Huda. We'll see you again soon. See
Okay.
you.
Thank you so
Bye.
much. Yeah, I'll see you.